Alright, now let's talk about ischemic heart disease manifestations. Now, angina is similar to any other type of cramping muscle pain. And angina in Greek actually stands for strangling. And this is exactly what's happening in ischemic heart disease. And there are three types of angina you need to be aware of: chronic stable angina, Prinzmetal's angina, and unstable angina. And we'll talk about each of these here. Now, in chronic stable angina, the myocardium is being strangled of oxygen because of a stable atherosclerotic plaque that is usually greater than 70%, preventing adequate perfusion at times of increased demand, such as exercise. Now, this is only transient ischemia of the subendocardial layer, and it happens during times of increased demand, such as exercise. So be on the lookout for a vignette that mentions something about resolution with rest. Now, on an ECG, you may see something like ST depressions, and the patient may feel better if they're provided something like nitroglycerin. Now, next up, we have Prinzmetal's variant angina. Now here, there's transmural strangling due to coronary artery vasospasm, and this leads to ST segment elevations because the entire wall goes ischemic. Here you'll see identifiable triggers such as tobacco, cocaine, or triptans in the vignette. Cocaine here is a vasoconstrictor, which is why chronic users suffer nasal septum perforations secondary to vasoconstriction-mediated ischemia. So in the question, look for signs of cocaine intoxication or nasal septal problems if you think cocaine is the issue here. Now, triptans are serotonin agonists which cause vasoconstriction of meningeal vessels in order to treat migraines. And as you would guess, in the coronary arteries, the triptans can also induce vasospasm. Tobacco smoke has toxins that directly inhibit endothelial cells from producing nitric oxide. Lower levels of nitric oxide means increased risk for vasoconstriction, which could potentially lead to vasospasm. So how would you treat Prinzmetal's angina? Well, you would remove the trigger, as well as provide medications to address the vasospasm, which could be calcium channel blockers or nitrates. Now next up, we have unstable angina, which is due to an unstable plaque rupturing that leads to incomplete coronary artery occlusion from a thrombus. In this scenario, you want to be on the lookout for ST depressions and or T-wave inversions. But remember, in unstable angina, you will not see elevated cardiac biomarkers, because if you do see these, this would be called STEMI or an NSTEMI, depending on if there were ST segment elevations or not. So with that said, how do you differentiate unstable angina from stable angina? Well, unstable angina does not improve with rest, while stable angina does. Now next up, we have coronary steal syndrome, and this is quite high yield. Notice there is a large plaque limiting blood flow within this left-sided vessel. Here you can see that this blood vessel is already maximally dilated to permit more flow past the lesion. Now in this scenario, if we were to give a drug such as dilpritamol or regadenoson, we would vasodilate all the vessels, including those unaffected by the plaque. So in doing this, do you think you would actually increase flow past the plaque? Actually, you don't, because here you begin to steal or shunt blood away from the already maximally dilated athromatous side to the unimpeded side. In this scenario, the blood is going to follow the path of least resistance, which is the path without the plaque. And this is the principle behind vasodilator-induced stress test, where the patient receives the dilpritamol or regadenoson and then a nuclear tracer to see which areas of myocardium become ischemic. And all of this is due to the concept of coronary steal syndrome. Now next up, we have sudden cardiac death. And this is when someone dies within 1 hour of the onset of symptoms. Now you can live through this event if CPR is performed and often defibrillation is required. But as you would expect, this must be caught very early. Most of the time, there's already pre-existing diffuse myocardial abnormalities, such as excess scar tissue from several old infarcts in the setting of coronary artery disease. People with scarred myocardium have areas of tissue that depolarize at different rates, which is how they may progress to an arrhythmia such as ventricular fibrillation, as you can see here. Now, if there's a family history of sudden cardiac death, especially during sleep or in previously healthy individuals, the vignette may be trying to guide you toward an inherited channelopathy, such as long QT syndrome or Brugada syndrome. Now, if a patient has a history of sudden cardiac death, or has a known cause of a potential fatal arrhythmia, an ICD can be placed to prevent future episodes. Now next up, we have chronic ischemic heart disease, and this is a result of repetitive ischemic episodes leading to fibrosis. In this image here, you can see the fibrous scar within the wall of the myocardium. Now in this scenario, we've replaced the viable myocardium with scar tissue, composed of non-contractile collagen. And as you would expect, the accumulation of this tissue will result in loss of viable myocardial cells, which then can progress to heart failure. Alright, now let's talk a little bit about myocardial infarctions. First, let's visualize the layers of the heart, and you can see these here. The endocardium, the myocardium, and then the epicardium. Your coronary arteries actually run within the epicardial visceral layer, and you can see an example of this here. Now, a transmural infarct occurs from occluding the coronary artery before it gives off its branches to the inner layers of the heart. This is a big problem here because now there is no blood to the entire wall of the heart, which is why it's called a transmural infarction. In this image, the shaded red area indicates ischemia or necrosis of the entire wall of the heart. This will lead to ST segment elevations on your ECG, as well as the development of Q waves. Now, all this is in contrast to a subendocardial infarction, which is usually due to stenosis or atherosclerotic change, limiting blood flow to the area of the heart last to receive the blood. And this is the area directly under the endocardium, called the subendocardium. Now you can see an example of an infarct of the subendocardium here, and it shows up again as the red shaded area. And on your ECG, this will show up as ST segment depressions, not elevations. And this is a key distinction between transmural and subendocardial infarctions based on the pathology of the coronary artery. Another important point to remember here is that cardiac enzymes will be positive in both STEMIs as well as NSTEMIs, but they will not be positive in stable angina or unstable angina. Alright, well that's going to wrap up ischemic heart disease manifestations. See you in the next video.